Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips and Practical Tips. Today, I'm going to share with you a case of retinoblastoma and how really to interpret cases of retinoblastoma. Even if you don't practice it, it's nice to know how to report the retinoblastoma because it has some special requirements for reporting. So this is a case of a 2-year-old boy who presented with right eye leukoria and of 6 months duration almost, with no family history of retinoblastoma. And as you can see here, the difference in the reflection between the right eye where there is leukoria or the white reflection, and it simply is a reflection of the tumor. This is the tumor being seen whenever we describe the leukoria. Now, grossly, it's very important to know that we have to obtain a section called the pupillary optic nerve section, which is in the middle really of the globe, because this is usually the one that contains the most informative details that we need to report whenever we encounter retinoblastoma. And this is a very low power scanning power magnification of the tumor, exactly similar to the previous one. So this is the tumor on the grossing, and this is here the optic nerve, and this is the anterior chamber, the cornea and the lens, and the white part here, this is the tumor that was actually depicted in the leukoria or white reflection. And this is again with the scanning power of the H&E. This is the tumor, the blue color, this is the lens, and this is the optic nerve. So exactly really correlating with the gross and correlating with the clinical findings of the patient. Now we have to go on high power magnification. And the first thing that we have to report or comment on is the degree of differentiation of the tumor. And this is in relation to how much really do we see rosette formation. So remember, retinoblastoma is a small round blue cell tumor, similar to lymphoma, similar to medulloblastoma, to hepatoblastoma. If we see only solid sheets of a tumor cells, this is high grade. If we see really prominent differentiation, more than 50% differentiation in the form of either Flexner, Wintersteiner rosettes with central lumina, or the Homer Wright rosettes with central neuropil, this is considered to be well differentiated. If we see less than 50% rosette formation, this is considered to be grade 2 differentiated retinoblastoma. And then we have to comment on the anaplasia, how much anaplastic is the tumor. And we can see here some features of anaplasia. There is apoptosis here, there is cell wrapping here, but really not diffuse and widespread anaplasia. So this is considered to be like grade 2 anaplasia. And of course, we frequently encounter calcifications as well as necrosis in retinoblastoma. And this is the choroid, where we have the pigment and we have the vessels. This is the pigmented retinal epithelium. This is the sclera. So this is towards the exterior part of the globe. And this is the tumor, which really what it did, it snatched with it the retina, causing retinal detachment and some fluid and hemorrhage in the subretinal space. But what is really important to report, and we should never release a report on retinoblastoma without commenting on two important structures, which is choroidal invasion and optic nerve invasion, because these are determinant of, for most part, of the stage as well as the prognosis for the patient. So choroidal invasion is number one that we should really make sure this is reported in the pathology report on retinoblastoma. What do we mean by choroidal invasion? Is the presence of a tumor in the choroid, which is the pigmented layer, the layer that contains the melanin pigment between the retina and the sclera, and it also contains vessels. This is why it's extremely important, because a tumors gaining access to the choroid means that they have access to vessels and lymphatics with the potential for spread. So how do we report choroidal invasion? It's not only the presence or absence of choroidal invasion, we have to give measurements. And the cutoff measurement is 3 millimeters. So the presence of choroidal invasion that is 3 millimeter or more in any dimension, is it whether this is horizontal, vertical, or in the third dimension in the eye, that is in direct touch with the sclera, this is defined as massive choroidal invasion and would donate a higher stage for the patient. This is high power magnification, just to show you that the tumor cells would be intermingling with melanocytes and myelin pigments within the choroid, and this is how we ensure that there is choroidal invasion. If the invasion is less than 3 millimeter, this is considered to be focal choroidal invasion. Still, it affects the stage, but the significance and the outcome is not as dismal as with massive choroidal invasion. Now, the other structure that we should comment on clearly, and because of this, we have sometimes to perform several 15, 20, 30 deeper levels, is invasion of the optic nerve. So we all aim to have a section that is as clear as this section. This is the optic nerve, and this is the tumor. This is the interior of the eye. This is the sclera, this part, because this is actually, the sclera is in continuity with the dura of the brain. The part where the optic nerve permeates or penetrates through the sclera is called lamina cribrosa, and invasion of the tumor through the lamina cribrosa is extremely important, again, because once the tumor gains access to the optic nerve, this will affect the stage, and then it has an access to the central nervous system, and the outcome would be dismal. So how do we report optic nerve invasion? Our landmark is this part, the part of the optic nerve that permeates the sclera or the lamina cribrosa. Anything before the lamina cribrosa is called the prelaminar. Anything within the lamina cribrosa, as is in this case, is called at the level of lamina cribrosa, and the most significant is actually whenever we see tumor beyond post lamina cribrosa, and then occasionally, if the tumor is so advanced, we might see the tumor at the cut end of the optic nerve, which is really associated with the worst outcome. So again, on high power magnification, this is the sclera that is in continuity with the dura of the brain. This is the optic nerve, and this is the part of the optic nerve that permeates the sclera at the level of the lamina cribrosa. And as you can see, the tumor has permeated the optic nerve only to the level of the lamina cribrosa, because this is the end of the sclera. If we draw an imaginary line here, the tumor has not gone beyond our imaginary line, which is the end of the lamina cribrosa. So how do we eventually report on this case? So this is retinoblastoma, grade 2, pathological stage T3A. It is a grade 2 tumor with many rosettes. There are other structures which are involved. However, what is really important are these two: choroidal invasion present, massive, with solid tumor nest 3 millimeter or more in maximum diameter, and the extent of a tumor nerve invasion at the level of the lamina cribrosa, whereas optic nerve cut end is free of a tumor. I hope you find this tip useful in your daily practice. Thank you.